and welcome once again to the Puscast podcast, a review of the infectious disease literature with commentary, this time covering February 1 through 14, 2007. I am now on iTunes with this podcast. Yes, I'm on iTunes. Thank you, Brent Fulcam. You are a god, or at least a minor deity, for figuring out what was wrong with my RSS feeds. I also, if you're interested, have a pair of widgets I have written that are available for Macintosh OS if you want to listen to this on a widget or get updates on the podcasts on a widget. This is brought to you by Puscast LLC, publisher of the Persiflager's Annotated Compendium of Infectious Disease Facts, Dogma, and Opinion, your uber hyperlinked electronic guide to infectious diseases at Puscast.com. All the opinions of those of Mark Crislip, MD, and Puscast LLC. Now CME accredited. Listen, take the online quiz, and get a half an hour of free CME. Thank you, Legacy Health Systems. Also, I have no conflicts of interest to mention. I am somewhat of a smartass, so this podcast may be filled with snarky asides and short political rants, but you're now warned. If you like this, listen to my Quackcast, a review of supplements, complementary and alternative medicines, also known as scams. You like the short intro? I listen to my listeners, and you all say you're sick of my long intros, so that is the intro to this podcast. Now we'll move on to the literature. As always, references are available online. Acute HIV usually presents with fever, sore throat, and rash. Sometimes, when it's more severe, patients can present with opportunistic infections such as PJP, PCP for you old school doctors, CMV, candidiasis, and a variety of organ systems such as renal and myocarditis. There's an article in this month's Clinics of Infectious Disease that presented a 16-year-old female who presented with multi-organ system failure. She had acute HIV disease and presented with liver failure, sepsis, myocarditis, rhabdomyolysis, and leukopenia, all secondary to acute HIV. So this case report adds to the panoply of unusual manifestations of acute HIV, and you should remember that the major risk factor for acquiring HIV is being a human being. Chance of ex-NBA players notwithstanding. Should you check the genotype on an HIV patient before starting antiretroviral therapy, especially if they are naive to antiretrovirals? Well, to me, this seems like a no-brainer. All of infectious diseases is about identifying the organism, determining its susceptibilities, and then instituting therapy. And it strikes me as stupid to start drugs on someone if you don't know what the optimal drugs are, even if the odds are that their organism is susceptible. The reason for this is sometimes patients beat the odds, and then you've wasted your medications and perhaps generated more resistance in your patients by giving drugs to which the organism is resistant. This was a study published in the Clinics of Infectious Diseases again that looked at genotypes in antiretroviral naive patients with an unknown duration of symptoms. They looked at a total of 103 patients. They are HIV positive. No one knew how long they were sick, and they checked their genotype. They checked. That's a new word. Checked, like worser. What they found was that 18% of patients had resistance to one class, 6 had resistance to 2 classes, and one patient actually had resistance to 3 different classes of antiretrovirals. In this study, 25% of the patients had some form of genotypic resistance to HIV of one sort or another. Why was this? Well, probably 2 reasons. One, they hypothesized that some patients were taking intermittent antiretrovirals for reasons that were not clear. The other is that patients who are sexually active are participating in high-risk behaviors with patients who are already infected with resistant virus. They concluded that it's probably cost-effective to check a genotype before instituting antiretroviral therapy, even in antiretroviral therapy naive patients, to which I respond, duh. In the words of the immortal Buckaroo Banzai, no matter where you go, there you are. Well, where do you go with your CD4 counts when you start antiretroviral therapy? This issue was addressed in Clinics of Infectious Disease this year when they looked at 6 years worth of CD4 cell counts in patients who remain suppressed on highly active antiretroviral therapy. And they found, not unsurprisingly, the higher your initial CD4 count was when you started therapy, the higher your endpoint CD4 count was. It looked like it took about 4 years for most patients to reach their plateau. I've always told patients incorrectly now that they'll reach their plateau after 1 to 2 years. But in this study, patients continued to climb for up to 4 years before they plateaued out with their CD4 cells. Now, if they started with their CD4 counts less than 200, their maximum that they got after 6 years was about 450. If they started between 200 and 350, they plateaued out at about 500. However, if their CD4 counts are greater than 350 at start, they plateaued out at almost 800, which is normal. Now, the current recommendations are to wait until CD4 counts are lower than 350 before instituting antiretroviral therapy, but this is a compelling study, long-term follow-up on patients with sustained viral suppression, demonstrating that the sooner you start the antiretrovirals in terms of their CD4 counts, the better off they're going to be in terms of their ultimate immune function. And in this study, 350 appeared to be the magic number. I always remember the Bugs Bunny takeoff on the Knights of King Arthur always had cirrhosis of liver. Well, what does cirrhosis do to your CD4 counts is the topic of yet another study in clinical infectious diseases, which looked at a series of 39 patients and looked at their T-cell sets. And they found that of the 39 patients, 65% had low CD4 cells. Of these, 26 patients, or 43%, had CD4 counts less than 350, and that 7% of patients had a CD4 count less than 200. Now, these patients also were more likely to have normal percentages, and that the worse the CD4 counts, the worse the splenomegaly, thrombocytopenia, and leukopenia. This study is important for two reasons. One, because it's impossible sometimes to get an HIV on some patients due to lack of ability to consent them. Hopefully a thing of the past as universal testing becomes more common. People would use CD4 counts as a substitute. It's a crappy substitute. There's a nice review in the Annals about 10 years ago on all the different diseases that can lower your CD4 counts. The other important thing is that if you have a combination of HIV and cirrhosis, you tend to advance faster, and you may not be able to use the CD4 counts as a good marker of your effect of your antiretroviral therapy in patients. So in other words, if your patient has cirrhosis, treat their CD4 counts with a grain of salt substitute. A couple of things about avian influenza. First, it appears mortality in humans is creeping up. Is now reaching about 68% in reported cases. The other, it tends to be a disease of youngsters. A study that looked at this in emerging infectious diseases this month found the vast majority of cases occurred in people up to age 35, and that the disease was much less common in people over age 35 for reasons that they said, quote, transcend sex, patient outcome, geographic location, and by implication, local, cultural, and demographic determinants. For some reason, it would appear that this disease more adversely affects children and young adults than it does the elderly, so I at least am safe for the short term. And the other interesting thing about influenza was a study that looked at the fact that one of the sources or potential carriers of avian influenza may be cats. It's an ongoing joke at Good Samaritan Hospital how much I do not like cats, or as I like to call it, the other white meat. They are nothing but pestilential vermin that are destined to primarily spread infection with no good feedback to human beings. But what do they have to do with avian influenza? Well, this was studied in the journal Emerging Infections this month. What they did was examine cats who had been around a die-off of birds in Germany and Austria and looked at them for the presence of influenza. And they found 2 cats that had evidence of influenza by antibody, though neither of them developed any symptomatic disease. There was also no spread from cat to cat of avian influenza. It's unlikely that cats would spread it to humans as well, since the receptors in humans that acquire avian influenza are found down in the lower airway, and one would have to have a cat coughing in your face, and the cats don't appear to get ill. But I still hope this will lead to lots of panic about people's cats and the rapid removal of cats from the Oregon surveillance for MRSA in our patients in the hospital. I remain skeptical on this issue, mostly because we have so much MRSA in the Pacific Northwest. 75% of patients presenting to the ER with infections due to staph have MRSA. So I think at some level we're losing the battle. Should we continue to fight it was addressed in an article in Clinical Infectious Diseases where they did weekly nasal cultures to surveil for MRSA. They obviously identified more patients with MRSA. About 2,000 more patient days in this study were spent in contact isolation as a result of the positive cultures. And they certainly had much better data as to who came in with MRSA and who was newly acquiring MRSA. Several problems with the study. One is that just culturing the nose probably underrepresents colonization burden of MRSA in their unit. And the other issue, of course, is that they didn't document or talk about prevention of infection. Certainly good contact isolation will prevent spread of infection in your hospital, but they didn't look particularly at the impact of doing all the cultures and the subsequent increase in contact isolation. I still remain skeptical that aggressive surveillance cultures is the right way to go. I think that the better approach is to focus on the basics, such as hand hygiene, which most data suggests that hospitals do a poor job at across the country. Until you get the basics down, such as washing your hands appropriately, spending extra resources on more advanced surveillance techniques, I think may be a waste of time and money. But certainly there is a huge debate in the ID literature and the infection control community on this issue. There was a similar study with VRE in the same issue of Clinical Infectious Diseases where they did stool sampling of patients instead of nasal cultures looking for vancomycin-resistant enterococcus. And they had the same effects in that they had better classification of patients. They found more patients with VRE, and as a result they had more patients spent in contact isolation. Because VRE may not show up as easily, they were finding far more cases in the MRSA, and they had an extra 5,000 contact isolation days that were done because of the VRE cultures. This study has the same caveats in terms of not showing a decrease in infections due to VRE, and also had the same issues as is the bang worth the buck. Probably, depending on your institution, VRE may be a more warranted thing to do. We probably have not yet lost the battle with VRE, and given the amount of vancomycin we're currently using, this will only become a huge problem. And when those vancomycin resistance genes jump to Staph aureus, as they have in the past, we're toast. Accompanying both articles is a editorial which nicely summarizes the issues of doing routine surveillance for resistant bacterial pathogens in hospital settings. I know many of you who've listened to this podcast have heard me harp on this issue before, but an article in Chest also brings home this issue. How do you treat community-acquired pneumonia? Well, the guidelines give you two choices, either a macrolide plus a beta-lactam or a quinolone as your initial empiric therapy. In this study published in Chest, they looked at the outcomes of patients with bacteremic pneumonia and found that those who were treated with a macrolide had decreased mortality compared to patients who were treated with a quinolone. So this is not the first study to show benefit with bacteremic pneumonia in patients who receive a macrolide. I personally think this is because macrolides mess up the production of virulence factors in organisms, i.e. proteins, and this is what makes patients do better, as opposed to getting a quinolone or a tetracycline. But the overall inpatient mortality in patients with bacteremic pneumonia was decreased if they received macrolide. Many studies have shown this, so I still think your initial therapy for community-acquired pneumonia, preferentially, should be a beta-lactam and a macrolide. More applied origin of species, which is all infectious diseases sometimes is. Of late, there's been a series of articles that have shown that the institution of the pneumococcal vaccine has led to the decrease in the number of strains of strep pneumo that are resistant to penicillin. This is because the most common strains are also the ones that are penicillin resistant and are also the ones that are commonly covered with the vaccine. So you give the vaccine to a bunch of children. What do you think happens to resistance over time? It decreases, but then you start to lose that advantage. And this was shown in a study in Clinics of Infectious Diseases where this environmental niche was filled by strains of strep pneumo that are not covered by the vaccine, but over time have become resistant to penicillin. And they've shown this quite nicely in this study, so that the benefit that we had of decreasing penicillin resistance due to the use of the pneumococcal vaccine was, as would be predicted, a transient phenomenon. To paraphrase the Borg, resistance is inevitable, and the other phrase in infectious diseases is use it and lose it. This next case report only caught my eye because my wife is a big-time gardener. She's currently digging a long trench in the backyard and keeps measuring me. I don't know what my height has to do with the depth and breadth of a rose garden trench, but be that as it may, there's an article that showed someone acquired Legionella longbeachii pneumonia from their potting soil. Usually you think of Legionella as associated with water sources, but in this particular case, this was associated with gardening, and specifically the organism that was isolated in the patient's sputum was also found in their potting soil, so adding another cause and potential risk factor for the development of Legionella pneumonia. You know, I saw the movie Fargo this weekend, and maybe I shouldn't have gotten my wife that chipper shredder for Christmas. Oh well. In terms of ventilator-associated pneumonias, there was a study that was published in the journal Critical Care Medicine this month that looked at early predictors for infection recurrence and death in patients with ventilator-associated pneumonia. These were studies that had been enrolled in an antibiotic study to determine whether 8 versus 15 days of antibiotics had adverse outcomes, and it did not. So 8 days still remains the duration of therapy one needs for ventilator-associated pneumonia. There were a variety of things that were associated with recurrence and death that one cannot change, such as age or sex. Well, I suppose technically you can change your patient's sex, but it's hardly worth doing while they're in the ICU. But the two things that were of interest was that if you had a non-fermenting gram-negative bacillus, that would be like a Stenotrophomonas, causing your pneumonia, you were more likely to die. But the other was methicillin-resistant Staph aureus ventilator-associated pneumonia. You were also likely to die. Now, what's interesting is that in these studies, everybody was on what was considered to be appropriate antibiotics initially by this trial. And I think this goes to the heart of the matter that we really don't know how to treat methicillin-resistant staph ventilator-associated pneumonias in patients in the ICU. I'm increasingly inclined towards combination therapies given the severity of this infection, but whether or not patients should be on linezolid or vancomycin plus rifampin or exactly what we should be doing for these patients is still unknown. Obviously, prevention would be of benefit, and eradicating MRSA in the world would be of benefit, but neither of those are likely to be successful interventions for this organism. Sometime in the not-too-distant future, staph will be resistant to all known antibiotics, and we will be back in the pre-antibiotic era for this organism. To quote REM, "It's the end of the world as I know it, and I feel fine." Is surgery the mainstay for the treatment of endocarditis? That may indeed be the case in the future, although this is annoying given how many patients who have endocarditis are also concomitantly use intravenous drugs, making them not the best of surgical candidates. But in this study, they looked prospectively at 426 patients with endocarditis and compared those who needed surgery to those who didn't have surgery, and found that patients who received surgery had markedly decreased mortality going up to over a year of follow-up. The separation in patients on the Kaplan-Meier curves was sudden, i.e. early in their course, and sustained for the duration of follow-up. So it's quite impressive how much better patients who had surgery for their endocarditis did compared to medical patients. Now, there were certain subgroups who also had increased mortality with their endocarditis, and those included diabetes, presence of a chronic intravenous catheter, and perivalvular complications. All of these were independently associated with increased mortality. It was pointed out that perhaps, and they could not prove this, that the patients in the medical group who did worse did so because they had indications that prevented them from going to surgery. But there have been both retrospective studies and now this prospective study to show that if you have left-sided endocarditis, that surgical therapy may be the optimal intervention for the treatment of your disease. Bringing home this issue that perhaps patients who died of endocarditis had contraindications to surgery was an article that was published in the European Heart Journal, and they looked at endocarditis and predictors of 6-month mortality. They found that mortality was most likely in patients who had a contraindication to surgery. Nearly half of the deaths in this study were in patients who could not have surgery due to other underlying contraindications. And in this study, they found that the 6-month mortality did not differ between patients who had surgical treatment and those who did not have surgical treatment if neither had any contraindications to surgery. So that if you could go to the OR, but you didn't need to, you did fine. It would appear, at least in this study, that perhaps the reason patients have a higher mortality rate in medically treated group is they are not surgical candidates due to the severity of their illness. In this study, 74% of patients with a contraindication to surgery died, as compared to 7% of patients with medical treatment who had no contraindication and 16% of those who had surgical treatment. So this is as always, an issue that is difficult to determine clinically. If you need surgery and can't have it, you're going to die. If you don't need surgery and don't have it, you're going to do well. And if you do need surgery and can have it, you'll probably do a little worse. This whole area remains murky. To bring home the importance of diabetes in the treatment of endocarditis was a published study in the European Heart Journal this month. It showed the marked difference in mortality in patients who had diabetes and endocarditis. If you were an insulin-taking diabetic, you had a 50% mortality rate, whereas if you were on oral anti-diabetic drugs, your mortality rate was 19%, and if you were not a diabetic at all, your mortality rate is 15%. So being an insulin-using diabetic is a very bad prognostic sign if you happen to have endocarditis. Meta-analysis, schmeta-analysis. This time the issue is IVIG in sepsis. There was a study published in the Annals of Internal Medicine that did a meta-analysis of about 2,000 patients and various studies to see if IVIG was of benefit in septic shock. Certainly it may have some benefit in group A strep infections, where I think it is a reasonable adjunctive therapy. They point out in the beginning of this article that there have been 2 studies that have been meta-analysis of IVIG in sepsis, one which showed benefit and one of which did not. So this is the tie-breaking meta-analysis. This one did show a benefit, and they found, in looking at all the studies in their particular meta-analysis, that there was a 26% survival benefit in about 2,600 patients in 20 clinical trials of those who got IVIG. The more you gave and the longer you gave it, the better the benefit. They just figured out that this would be, in terms of numbers needed to treat, about 9, and that the cost would be about the same as activated protein C. At least we have activated protein C. IVIG continues to be in short supply, so whether or not this is benefit of not definitively, we need a good randomized controlled trial in patients who have sepsis to see if it is of benefit. With multiple meta-analyses showing benefit or no benefit, it would be nice to have a definitive trial for this drug, which, as I say, is in short supply anyway. I personally would bet it would be dependent upon the organism and will never have that trial. If your sepsis was from staph or pneumococcus, I would bet that the presence of IVIG would be of benefit, whereas if your sepsis was from Stenotrophomonas or Candida albicans, it would probably be of much less benefit. I think it would depend in part as to whether or not the organism you are infected with requires the presence of immunoglobulins for optimal death. Can you get C. difficile if you don't have a colon? Well, it would appear yes. If you get your colon removed, sometimes the surgeons will construct an ileoanal pouch to serve as a reservoir after removal of your colon. And there are now a couple case reports of patients who have developed C. difficile in their pouch. So yes, you can get C. difficile if you don't have a colon. Still, the big question is whether or not you can get this if you have a total colectomy and an ileostomy. That is still up in the air. I'm sure you've heard about the salmonella outbreak associated with peanut butter. This is apparently a point contamination of a peanut butter plant that subsequently spread the salmonella-infested peanut butter across the United States. This is not the first, nor will it be the last of these types of outbreaks. With the centralization of the food supply and the ability of these organisms to grow despite our best efforts, I'm sure we will see in the future other point outbreaks with other human pathogens. There's a certain inevitability to these types of problems. Though I did hear that someone's already suing the peanut butter company over their salmonella outbreak. The secret to avoiding these types of illnesses, of course, is to only eat deep-fried food, though I do find it difficult to deep-fry my peanut butter and jelly sandwiches and continue to enjoy eating them. There are a few pathogens as infectious as shigellosis, which affects maybe 500,000 Americans a year and requires a paltry 10 organisms to start an infection. It has been inferred over the years that this may be spread by sexual transmission in men who have sex with men, and this was confirmed in a case control study in San Francisco published in this month's Clinics of Infectious Diseases. In this study, they looked at an outbreak of shigellosis between 1998 and 1999 and found that two big risk factors for the development of shigellosis for men were HIV infection or direct oral anal contact. For women, it was foreign travel that was associated with the development of shigellosis. So it would appear that in the population of men who have sex with men, that shigellosis is predominantly a sexually transmitted disease. And as long as we're on the topic of diarrhea, a study in Thailand that looked at the empirical use of quinolones versus azithromycin for Campylobacter found that a single dose of azithromycin, 500 milligrams, was sufficient to treat Campylobacter diarrhea. Quinolones can't be used because in that part of the country, quinolone resistance rates approach 85%. So a single dose of azithromycin is a sufficiency for treating Campylobacter diarrhea. I always hate it when data gets in the way of deeply held beliefs. There's a nice book called Biology of Plagues, which goes through the history of bubonic plague in England and comes up with the conclusion it was not due to Yersinia pestis. It's a fascinating book. However, there's a article published in Emerging Infectious Diseases where they went back to the dental pulp of patients who had died of plague in the 16th century, and they looked for presence of plague DNA, and indeed they have found Yersinia pestis serotype orientalis as the putative agent of plague in this series of patients. These patients died in the 5th century of plague, and it would appear that, at least in this epidemic, it was probably due to the Yersinia pestis. In India, the treatment of choice for typhoid fever is ciprofloxacin. Guess what happens when you use lots of ciprofloxacin? You're right, you get resistance. And in India, the amount of susceptible strains of Salmonella typhi, the agent of typhoid fever, has declined to 11% in the year 2004-2005. Now, the interesting thing about this is they have not been using TMP sulfa and they have not been using chloramphenicol. And those had a 90% resistance rates in 1990 because no one's using these drugs against typhoid fever. The rates of resistant strains to TMP sulfa, ampicillin, chloramphenicol have fallen to 5.6% in 2004 to 2005. So the heavy use of ciprofloxacin has led to quinolone resistance, but subsequently removing the environmental pressure from the organism has led to a resumption of susceptibility to the older agents, i.e. chloramphenicol, ampicillin, and TMP sulfa. Use it and lose it, or don't use it and gain it back. Speaking of using it and losing it, tuberculosis is getting increasingly nasty. And the emerging infectious disease is a study that looks at XDR-TB, or extended drug-resistant tuberculosis. And XDR-TB is an MDR-TB, i.e. resistant to INH and rifampin, for example, the first-line drugs, that's also resistant to 3 of the second-line drugs. What this means is that you basically end up with strains of tuberculosis that you cannot treat, that they are not susceptible to enough antibiotics that you would expect that extended regimens of multiple agents would cure them. What percentage of patients in the world are now XDR-TB? Well, in this series it looked at 17,000 isolates from all over the world, except for North Korea. They found that 10% of the strains met the criteria for extended drug-resistant tuberculosis. One would expect, since this often occurs in association with the AIDS epidemic, that we are only going to see increasing amounts of XDR-TB in the future. And goes to the heart of the fact that the global public health program stinks on ice, is underfunded, and tuberculosis thrives in war, poverty, and starvation, which does account for most of the world. It's sort of a bummer, huh? The New England Journal of Medicine has a nice editorial on the topic in the month of February. I always pronounce the R in February is February. I also pronounce the N in Wednesday, so it's Wednesday. As a minor note, in diabetics who develop fungal infections, represent a subgroup of patients that are at high risk for going on to develop ulcers and diabetic foot infections. So one of the markers you can use is for the presence of onychomycosis, which in these patients is usually Trichophyton rubrum as the primary etiology. If you start to see a toenail infection, in and of itself, not very worrisome, but it is a sign that they have more underlying vascular disease of their foot, and they need to be warned to watch for foot ulcers, etc. To diagnose invasive pulmonary aspergillosis remains a difficult problem clinically. The cultures have low yield, bronchoscopies with biopsies are often dangerous in patients who don't have platelets, and the galactomannan assay, while helpful if positive, is least likely to be helpful in the patients in whom you most need it. The test that may be of help, at least for deciding on whether or not patients have invasive pulmonary aspergillosis, is the CAT scan of the chest. This study was published in Clinical Infectious Diseases, and they looked at 235 patients who had invasive pulmonary aspergillosis. And they went back and looked at their CAT scans. And they found that with the presentation of pulmonary aspergillosis, 94% had greater than 1 or more macronodules, and 61% had the halo sign. Other things can be seen with Aspergillus pneumonia, including consolidation, which occurred in 30%, infarct-shaped nodules, which occurred in 27%, cavities in 20%, and air crescent signs, 10%. Patients who had the halo sign had a better response than those who didn't, and a greater survival than those who didn't. So if you have a patient and you're worried about invasive pulmonary aspergillosis, get a CAT scan. If you see a halo nodule, I have trouble with that word, start the patient on anti-aspergillus therapy, ASAP. There's also a good review of the prevention of fungal infections in Clinical Infectious Disease this month. It goes over the pros and cons of some of these studies, as well as optimal use of prophylactic antifungal therapies. I love the headline in Medscape on this one. It comes out of Lancet, but their headline says, causal link confirmed between antibiotic use and resistance, as if we haven't known about this for 30 years. But this was an interesting study in that they did the following. They took 347 healthy volunteers, and they either got azithromycin 500 a day for 3 days, or clarithromycin 500 BID for 7 days, or placebo. And they did daily pharyngeal swabs and then looked for resistance. Now, the thing to point out here is how quickly resistance develops. Resistance peaked at day 4 in the azithromycin group. So within a day after stopping your 3 days of azithromycin, you had your maximum amount of macrolide resistance, and it peaked at day 8 in the clarithro group. The day after you stopped your clarithromycin was the day you were most likely to have clarithro resistance. And the other interesting thing is that resistance was found up to 180 days after stopping antibiotics. Now, there's similar studies that were done in the 50s where oral antibiotics led to resistance within 3 or 4 days in stool cultures of bowel organisms. So resistance occurs very quickly when you give patients antibiotics, and it persists for a long time. Giving antibiotics is not a trivial thing to do. I personally expect to see tons of resistance to daptomycin and to linezolid develop very quickly in staph once we lose the ability to use vancomycin. And the other issue is that ertapenem, a new macrolide, is already being found to be resistant in E. coli. And there was a report that was published in Emerging Infectious Diseases that found that a mere 10 days of exposure to imipenem in a dialysis patient led to a ertapenem-resistant E. coli. That resistance was explained by a combination of a defect in its outer membrane protein and, wonderful, an extended spectrum beta-lactamase. Even an antibiotic like imipenem can quickly breed resistance to a class of antibiotics in the right host. Again, I keep saying it, use it and lose it. I have this horrible urge to refer to imipenem as a strong or powerful antibiotics, but all the house officers at our program know that I always say the way you can tell somebody who knows zero about antibiotics is if they refer to them as strong or powerful. And I don't want to have it on tape to have my nose rubbed in it forever. This is not tape. That's how old I am. I don't want it digitally mastered in MP3. So, yippee skippy, that's it. We're at the end of another podcast, the Persiflager's Infectious Disease Podcast, a review of the infectious disease literature with commentary, brought to you by Pusware LLC, the publisher of the Persiflager's Annotated Compendium of Infectious Disease Facts and Dogma, your uber hyperlinked electronic guide to infectious diseases at pusware.com. Now CME accredited. Listen, take the online quiz and get a half an hour of free CME, thanks to Legacy Health System. Now available on iTunes. I finally got my RSS feed working. Thank you. You can now get up to date by just booting into iTunes and subscribing it. If you happen to like this, please write a review, a good review. Give me 5 stars. Say how wonderful I am. I have an enormous ego, and my children check the iTunes site every day to see how I'm ranked and what the reviews are. So make my children proud by letting their father get more 5 stars on his podcasts. There's also now a widget, actually there are 2 widgets available for both listening to my podcasts and for the RSS feed if you have a Macintosh. If you like this, listen to the Quackcast, a review of supplements, complementary and alternative medicine, i.e. scams. I'm currently working on one on naturopathy. Bandwidth ain't free, so please feel free to purchase this compendium and support the podcast, or pretend I'm NPR and think about how nice it would be to support it, but let someone else do it. This is copyright with the Creative Commons license, creativecommons.org. The music is by my eldest son when he was 12 years old, improvising on the guitar. For comments, feel free to email me at mcrislip@pusware.com. And as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation, goodbye. Now I'm going to go watch Superman on DVD with my youngest son as it rains in Portland, Oregon.